most common thing is compliance. Are these patients taking their insulin? And a good history will help there. Number 2 is infection. And you would be surprised at the types of infections. So you can think of a urinary tract infection. If their patient is young, you can think of appendicitis. You can think of a gastroenteritis. Patients with repeated DKA infections over and over again. In a patient who's got a headache or a sinus headache, you've got to think of some of these exotic infections like mucor. Now this is important because mucor is a fungus that invades and it needs to be detected early. So think about that in a DKA patient who, if you look in the roof of their mouth, have a black spot on the top of their palate, or you see black stuff inside their nose. These patients need surgical intervention immediately. So look for those types of things in patients who are coming in with repeated episodes of DKA that you really can't find a good source on. The other thing is, because these patients have terrible, terrible cardiovascular disease, think of a myocardial infarction. So, EKG. Are they having ST segment changes? So the key here is, get all excited about treating DKA and correcting those electrolytes, but you got to think about, why did this patient go into DKA? The last thing I'll stress before we go is, again, insulin. Why are we doing it? Why are we doing insulin? It's because we want to shut down, not the glucose. It's not the high glucose that's the problem. We want to shut down ketone production. In fact, we want that glucose to fall slowly, and we want the fluids to go in slowly. We don't want it too fast, because we can cause cerebral edema and shifts. But what we want to do is shut down ketone production. So unless we have evidence that ketone production has been shut down, either through a beta-hydroxybutyrate level, which is undetectable, or an anion gap level, which is less than 12, we want to keep going with insulin. In fact, we use IV insulin at the beginning. And what we do is we transition to subcutaneous insulin, some long-acting insulin, and we do it with about a 2-hour overlap to make sure that the patient doesn't go without any insulin during that time, because we want to shut down the ketone body production, which is occurring in the matrix of the mitochondria. Okay, well, I hope that helps. Thanks very much for joining us.